Hey, good morning, everyone. Welcome to Euronurse. Got the time changed a little different for today. We're starting an hour early. Threw me off. I forgot to hit that start button. So sorry we're a little late, but we're still here. And if you're watching us on YouTube, LinkedIn, or Facebook, welcome to the show. And for you YouTubers, be sure to hit that subscribe button. A couple weeks ago, I told you we just rolled over our 300th subscriber. We just turned over 400 subscribers this week. So keep up the work. If you're new to the show, be sure to check out our website at euronurse.com where you can find out more about the show. It's also the best place to go to watch all of our past episodes, and we've got 62 of those episodes for you. Hey, if you want to listen in your car, we do have an audio podcast available. Go to our Euronurse Plus area on the website, and you can listen to us in any of your favorite formats. I do have a newsletter that goes out every Monday that has more information about the show. Be sure to sign up if you haven't been getting the newsletter. Got a lot of good information in there for you. And if you're attending the show live and you have questions, be sure to put them in that comment box. We'll always get to your questions. Now, we got a great show. Lais Heideman, one of our regular experts, is going to be joining us to talk about BCG today. And let's go ahead and bring in our expert panelists today. Hey, Lais, welcome to the show.
Good morning.
And another nice day to get a beautiful show going here. We're a little cloudy where I'm at. I don't know how weather is in Iowa, but it's always a good time to have a good show. It's just the two of us today. I think our early start time caught a few of our regular panelists still sleeping. I don't know. But hey, it's always good. I do have a favorite story and an introduction of myself, and then I'll let Lais introduce herself. But I am the host and producer of the show. Started this show a little over a year ago, and I've been involved in urology for 40 years. Really enjoyed all the time I spent taking care of patients and wanted a way to kind of pass this forward to the next generation that's going to take over. And that's where Euronurse came in as a way to do that. Now, interesting story that I thought I'd share kind of goes with the BCG theme is this goes way back. My wife and I were going shopping one day. We're in one of those big malls, where you can walk through and all the stores are there and you're in clothes. So, it's kind of, you don't have to be all dressed up in coats and stuff. Anyway, we're walking and all of a sudden I kind of recognize somebody coming towards me in the audience or in the mall. And when you get that where you kind of, you know them, but you don't remember who it is and their name. Well, this lady walks up and says, "Oh, Vic, nice to see you." And I think she could read my face and know that I wasn't really kind of figuring out who she was. And she goes, "Well, you probably don't recognize me with my clothes on." And I'm like, all of a sudden she realized that what she just said in an open mall with my wife. All embarrassed. She goes, no. And instantly I remembered she was one of my patients for BCG. So of course we had a good laugh over that, but I'm sure that anybody in this profession has had that experience where, there's one of you and everybody seems to know you, but then you run into somebody and you know them, but when it's not in your office setting, you kind of get mixed up. Anyway, that's my story for this week. And I'll bring Lais in. What's your introduction? If you got a story, otherwise we'll go into your talk.
All right. Good morning, everyone. And that is a great story, Vic. Really, really funny. But good morning, everyone. Great. It's a pleasure to be here again. I'm Lais Heideman, a nurse. I've been in urology for over 10 years, certified in urology, still work in urology. Love it a lot. My fun story, more of an interesting fact, and also goes kind of with the BCG theme. So as I've shared before, I'm native from Brazil, and being born in a foreign country in the 80s, I was vaccinated with the BCG vaccine for tuberculosis. So very interesting, and it's something that we'll talk about here in the presentation a little bit, it's a little bit different than your regular Joe that just gets a PPD test. But that's my fun fact. Not everybody gets to share that really today. So
that is interesting. Well, we've got some comments coming in here, so I thought we'll share those real quick. Katie Bortel says, "Good morning from Chicago. It's raining and cold here." Absolutely. Boy, the weather changed here. Susie Swain, good morning. It's dark still, but I think it's raining here in Centralia, Washington. Hey, Susie, that's getting up pretty early this morning to come to the show. Thanks for joining us. Jennifer Shipstad, good morning. Cloudy and cold in Minneapolis. You guys are really the ones who are the brave-hearted. I went to Minneapolis a while back for something with Medtronic, and man, does it get cold there. Heather Hansen, good morning from Moorhead, Minnesota. Same weather here. Well, I'm glad we're sharing this great weather. And Nancy from Brownlee. Nancy Brownlee. Hello, Friendswood, Texas. Wow, that sounds like a nice place to visit. Raj, good morning. Houston is warm. All right, somebody's got some decent weather. And hi, Nancy. My brother-in-law lives in Friendswood. See, it's a small world, isn't it? So, yeah, welcome, everybody. Glad to get those introductions. Glad everybody's joined us for the show, too. All right, I'm going to switch over and let Lais take over and present here on BCG.
All right. Well, good morning again, everyone. We'll get started here on this awesome BCG skill development PowerPoint, and we'll talk a little bit, first of what is BCG, right? I just shared I was vaccinated for BCG, and that was the initial purpose of this vaccine. Many foreign-born persons, so true example here, are BCG vaccinated. This is a vaccine administered in countries with high prevalence of tuberculosis. It's just another vaccine on the vaccine chart. BCG usually is not recommended as a vaccine for tuberculosis in the United States, as there's not, a high rate of tuberculosis here. And it also messes up a little bit. It gives you a false positive on that PPD, that skin test. So now, interestingly enough, in healthcare, you develop a medicine, a vaccine for one purpose, and next thing you know, you're using it for something else. So Dr. Burton Zebar in the 70s started using the BCG vaccine in different ways, and this was to both treat melanoma and bladder cancer. Now, I do want to put a little disclaimer out there. Please make sure that you check your facility's policy for BCG mixing, handling, administration, etc. Each facility should have their own policies and rules. So this is just informational. And of course, as a nurse, I can't skip the 5 rights of medication administration. Make sure you always have your right patient, the right medication, that you're administering in the right route, it's the right time, and the right dose. Couple things to consider before BCG treatment. Of course, if someone has had a traumatic, catheterization recently, or traumatic, cystoscopy, anything introducing to the urethra that might have been traumatic, or any urinary surgery. Here, mostly we're talking about those, TURBT, so transurethral resection of bladder tumors. You want to make sure that you are allowing enough time to heal, for the patient to heal before you're starting your BCG course. Immunocompromised individuals should not have the BCG intravesical treatment. And any patients with an active infection should also not have their BCG treatment while they're on treatment for their infection. Now, this covers both urinary tract infections as well as any concurrent infections. When we're talking about preparation of the BCG vial, a lot of folks think of the hood and whatnot, and that is how it is mixed in various different facilities. We'll have a little picture of what that looks like here shortly. But if you look at the insert on the BCG itself, it does talk that, they do recommend mixing that in the biocontainment hood. But if you don't have that and supplied that you are in a room with good ventilation, you can mix your BCG with respiratory protection, eye protection, gloves, etc. So do recommend that we use, those chemo gloves. I think everybody's familiar with those. Eye protection, of course, because you don't want that to splash into your eyes, as well as, gown, mask. You don't want this to get into any mucous membranes, any splashing, or perhaps, in the winter here, we all have crummy weather right now. You get, dry hands from washing it so much. Any surface that could have that exposure, to an open little sore, you want to make sure you are protecting, both for the mixing portion, but also the administration. Now, this slide is looking a little goofy. I apologize. It's hard to read, but this essentially is talking about, you must mix BCG using a aseptic technique. One thing that is very important, whether you are just mixing BCG in a regular room with good ventilation or hood, in a hood, you want to make sure that you are using a separate area that is dedicated for the mixing of the BCG. So take, for instance, the clinic I'm at, we have a med room, right, where things like rocephin are mixed, and we draw, different lidocaine and different other medications. We have a completely separate area where we mix BCG. Now, note that after mixing BCG, if you have any spills, you want to make sure that you're cleaning that immediately using a sanding cloth and or a bleach solution also is recommended. Again, I apologize here for the slide not being very good to read. This is talking about the first method of mixing BCG. So this method is usually, more so used if you're mixing it in a hood environment, which kind of sucks in that air of the area that you're mixing. So your hands are into, the actual hood, and it kind of has that proper ventilation that's sucking the air immediately. This literally just uses a syringe where you pull some of that preservative-free sodium chloride back, mix it into the vial, swirl it around a little bit. You don't want to be too aggressive because you don't want to create clumps. And then from there, you put the small mix, about 3 mils, into your catheter tip syringe that should have about a total of 50 mils of that sodium chloride, the preservative-free, into a catheter tip syringe. And then, of course, you have your catheter for administration. Now, the second method, and I would say one of the most common methods of mixing that you do see out there in clinics, are using a closed system for reconstitution. So here you have 2 examples, to the right and left. Some individuals, by the way, do use that sodium chloride in a little bag and, dispense the BCG via gravity, or it can be on a catheter tip syringe as well, just from the vial of the preservative-free. The main differences in this mixing method versus mixing it regularly with the syringe are, of course, that this is made so that it's a very protected closed system. Now, don't get me wrong, you still want to make sure that you gown and that you wear your gloves and eye protection, because, who knows? But essentially, these systems come with specific adapters that you kind of spike your vial, spike your bag, or your other vial, so the BCG vial and the sodium chloride vial, and then you're able to pull, and mix in a little bit of a more controlled environment. Some things when you're thinking about, okay, have my patient here for their BCG treatment, we want to make sure that they're giving you a voided urine specimen. You want to run a basic urinalysis. Of course, here we're looking for things like potentially, nitrites. We're looking for leukocytes. We're looking for blood in the urine. You want to make sure that in addition to, having the conversation with your patient of hey, do you have any infections? Do you feel okay? You also want to check their urine. It does talk about avoided urine specimen because with catheterization, it may be a little, you might get a little blood there. And so you want to make sure that avoided specimen, which again is ideal. If a patient has gross hematuria, it is not recommended that they get their BCG treatment. The other thing I'll mention in regards to the urinalysis is that sometimes, we all have patients who have colonized bacteria, you name it. So please know that each patient is assessed, according to their own medical history and what would be appropriate for them. These are kind of general rules to go by. And of course, this is always provider dependent. That will say, yep, we're good to go for this treatment. Something else, of course, we always talk about hand washing and good, personal hygiene measurements. This is not, of course, only because it's the right thing to do, but you also want to make sure that before you're eating, drinking, smoking, handling anything else, that you really do, wash your hands after handling that BCG. Now, when we're talking about, administering this to the patient after you've obtained your urine specimen, you're good to go. They feel well, they don't have a fever, we're good to go. We're having them undress from the waist down. We're explaining the procedure to the patient, making sure that they understand that this medication is administered through a catheter. That does not necessarily have to stay there. But it's so that we can get the medication into their bladder and that we're obtaining consent and that the patient knows all the steps. Sometimes for male patients, you may find individuals that use lidocaine jelly. So that viscous lidocaine to sit there a little bit. That's not necessarily a must. It's kind of that verbal anesthesia, so to speak, and making sure that you have a well-lubricated catheter will do just fine. When you are getting your patient ready, the recommendation really make sure you have an area, checks, covered their legs and really only expose the area that you need for catheterization. Now, of course, this is different for males and females. And do perform the catheterization according to your clinic's protocol. We do go ahead and empty the bladder completely. Again, as a reminder, individuals are going to have to keep that BCG mix in their bladder for up, to 2 hours so that it can kind of marinate in there and do its thing. And so we want to make sure that we are emptying the bladder so that they don't feel like they have to go to the bathroom right away. Again, using the chucks, making sure that you have all the things that you need to you insert your catheter, you connect either your tubing or your catheter tip syringe there, and usually you want to make sure it's primed, of course, and you kind of let it go by gravity. Sometimes it might take a tiny little push to kind of get that flow going, but you want to make sure that you are allowing the solution to go down by gravity. So of course, as the patient's laying down, you raise your solution, higher than the patient so that gravity can do its job. I always like to have gauze and, additional pads right there for me. So that especially after you remove the catheter, that can be some droplets and whatnot. You want to make sure that you're cleaning the area for the patient and you're not letting that sit there. We do, of course, want to make sure that we're providing patients with all the privacy that they deserve and really only exposing the areas that we need to work with. When we are talking about removing that catheter, again, squeezing, kind of holding that catheter tight and pinching it a little bit so that any remaining, solution doesn't just fly everywhere, not only onto your patient, but onto yourself also. And, of course, make sure the catheter is intact and that you are cleaning any potential drops that you did have. Once that's removed and good to go, you want to make sure that you are discarding of your catheter and chucks, etc., appropriately. Again, this will vary from facility to facility. We treat our BCG as we would any chemo waste, and so it goes into a yellow bag and it gets taken into its appropriate area. And this is, of course, the time where you are reinforcing with your patient that, we would like for you to keep this into your bladder for as long as you possibly can. There are instances where patients do have to keep a catheter in, plugged catheter, as they're unable to hold in the urine themselves. And so, this is also a possibility there, but reinforcing with the patient those post-procedural, expectations, which we'll go over here in a little bit, is really important. And also making sure that they have their follow-up visit is really, really important, because BCG is not a one and done. It is a series of treatments. This chart here kind of goes a little bit into, what a patient-facing instruction would look like a little bit. So we do say, hey, maybe limit your fluid intake a little bit, the hours leading up to your procedure. So again, that way they're able to keep that solution into their bladder for the 2 hours. It talks about how a catheter is inserted through the urethra, and that BCG medication is then inserted through the catheter. This chart here talks about clamping the catheter. And again, for someone who might be incontinent, who might not be able to hold that solution on their own, this is an alternative where then in a few hours, the patient would have that catheter removed. Does talk about having that repeat procedure about once a week for 6 weeks. Now, to be clear, that's the induction therapy. So that is usually the initial therapy that the patients receive. There's also maintenance therapy for BCG, which would be about 3 weeks, once a week. When it comes to patient education, which we all know, extremely important here, we're talking about trying to not void 1 to 2 hours post-procedure, if possible. After voiding, they want to make sure that they're using about 2 cups of undiluted bleach and pouring that in their toilet, closing the lid, and just letting that sit there for 15 to 20 minutes before they flush. We do highly recommend to close the lid of the toilet to prevent any splashing, as well as sitting to void for males in this case, as you want to avoid any potential splashing that could happen if you're standing to urinate. Some other things that we talk about, of course, if the patient were to notice any splashing into their hands, genital area, or really anywhere, they want to make sure that they're washing, cleansing that area to avoid any potential irritation to the skin. We do recommend avoiding public restrooms and also urinating, say, in the woods. So maybe don't go camping right after. And we do say increase your fluids to make sure you're diluting the urine thereafter. Some common side effects that you can see: some blood in the urine. Now, again, I caution, because we're not talking here about bad ketchup-like, cherry-colored, that you don't want, but some, minor blood in the urine can be expected. A low-grade fever sometimes, some tiredness, urinary frequency, urgency, perhaps some burning with urination. Now, something really important to enforce with your patients is that if they develop a fever of, 101 or higher, they have chills, rash, prolonged cough, joint pain, anything like that for over 48 hours, they most definitely should be contacting their doctor's office as soon as possible. Some additional considerations. So, things that as nurses, we really should be thinking about and educating our patients. They're, human beings that have normal lives. And one of the big things to consider is if the individual is sexually active, they do not recommend them to have intercourse for at least 48 hours following that BCG installation. And throughout the procedure, the course of their BCG treatment, so say the 6 weeks or the 3 weeks or however long that they would be doing their treatment. They do recommend, of course, that they wear a condom. Also for anyone who might be of childbearing age, they do not, of course, recommend that you are trying for a child. So, contraceptive methods are recommended during the period of your treatment. Now, sometimes you may have some urinary incontinence, kind of with that urge incontinence, perhaps. If that happens, your clothes become soiled. You want to make sure that you are, laundering that right away and that it is separate from other clothing. Hot water, if all possible. And of course, make sure that you're always performing good hand hygiene after handling clothing or any items like that. Alongside with urinary symptoms, and this is not unique to BCG treatments, but as urology nurses, various different procedures or post-procedure, or really even sometimes when you're talking about urinary symptoms with patients, we do talk about increasing your fluid intake, but kind of watching what you drink. So, caffeinated beverages, bladder irritants, alcohols, every individual is very unique to what they're sensitive to. I've had individuals who, tomato sauce and spicy food were pretty irritant to their bladder. So just, kind of making sure the patients know that bladder irritants should be avoided. They should be drinking enough fluids. And this, could go anywhere from just good old plain water to things like Gatorade and, juices, etc. So sometimes if a patient may be having severe, urinary symptoms, their provider may prescribe something that could help with that as well. So some first aid measurements, and here is, say you are mixing BCG and you were not using eye protection or whatever may happen. If you get it in your eyes, you want to make sure that you are flushing it. Most clinics have an eye flush station. You want to make sure that you remove your contacts if you do wear them, and then, seek medical attention as soon as possible. Skin contact, you want to make sure that if it's in your clothes, you're removing the clothing, also flushing the area with copious amount of water. If for whatever reason you ingest it, you want to make sure you're seeking medical attention. And if someone ingested and they, for example, needed CPR, make sure that you're not doing, a straight mouth to mouth. And of course, please do report the incident according to your facility's protocol. A lot of information here, but kind of just in a synopsis, it is talking about some contraindications, warnings, and precautions, when it comes to the BCG administration. It is a Category C medication. And so, it is not known. So, for example, if someone's pregnant and they were to need this treatment, there's not a lot of information out there. There's, not a lot of studies in humans to whether this is safe. Same thing with lactating mothers. They do talk about how BCG should not be administered to immunocompromised individuals. It should not be administered if someone has a concurrent infection. So it's not only that urinary tract infection, but say someone has a ear infection or a skin infection. We usually, recommend to wait until that's resolved before you start your treatment. They do say, please don't administer BCG for individuals who have active tuberculosis. BCG is not a vaccine for cancer, and it does contain that live little mycobacteria, and so hence the reason of why it must be prepared and handled appropriately. We do talk about monitoring patients, for their symptoms. We talked about if their symptoms last over 48, 72 hours, if they have a really high fever, this could perhaps be a sign of a systemic, manifestation there. And so they should be calling their doctor's office, seeking medical attention. This can sometimes cause symptoms that mimic things like prostatitis, orchitis, And if those last for, more than 2 or 3 days, most certainly it could suggest an active infection. Lastly, for those who have handled BCG for a very long time, now unlike the BCG vaccine that's actually injected into your body, but it could perhaps start showing that tuberculin sensitivity, excuse me. And so that's something to be aware of, if you handle BCG a lot. And that brings the end of the presentation here. I see that perhaps there were some questions there, Vic.
Yeah, I'm going to go ahead and bring those up. That great presentation. I got to really commend you that you think you covered everything. Be a few things I think we'll bring some questions up. I've got a few discussion points I'd like to talk over with you, but let's bring up our first one here. This is by Raj. I received BCG when his child first job PPD positive, and I had to take 3 months of the medication for TB and X-ray. And we talked about that before the show started because
we did.
So why don't you go ahead and explain what you said about that?
Yeah, so I was on the same boat there, Raj. So I received the BCG vaccine as a child as well. And prior to starting clinicals in nursing school, had to, do the whole physical and PPD test. And, I could argue to whether there was an actual induration or some skin irritation, but knowingly that I had that BCG vaccine, they most certainly wanted me to get an X-ray. I did have some avid discussions with the provider to whether a medication regimen should be initiated or not. And at the end, I had a clear X-ray and a really just some mild skin irritation on site and not actual induration. And so I didn't have to start a medication regimen. But it is something to be aware, right? If someone has had that vaccine, that could be the route that is taken.
Yeah. Good. Thanks. Katie says, if BCG is not available, what else can be used and the timeline? So I know we've had periodic shortages of BCG and we've all had to deal with it. We've had waiting lists, etc., for our office. But what has your experience been?
Yeah, likewise, I swear it feels like this is something we've talked about since I became a nurse in urology, the BCG shortages, right? One time, funny enough, I even Googled how BCG is made because at this point, I just wanted to know why we had such a shortage and why we couldn't do more. But what we do, so likewise, we had wait lists. Some patients, now of course, this is provider discretion and it having other intravesical treatments. So whether that be mitomycin, gemcitabine, Valstar, and others did, have wait lists. We also sometimes did not deliver the full vial dose, and so we split, the vial into different sessions. And so, for example, we try to bundle our BCGs, right? So we're doing a whole bunch of them on Monday. It might be that, the vial's not used in its entirety, and had to definitely get creative there. But lots of patients that had alternative treatments, like mitomycin and gemcitabine. So
you kind of do what you have to do. And, one of the things that I recall quite a bit was the lower dosages of BCG. We would give, 1/3 doses, and often patients have had some intolerance. They'll develop a lot of urinary urgency, not the high fever type where you're worried about a sepsis from BCG, but more the irritative symptoms that they were having complaints of. And so we tried lower doses, like a 1/3 dose on those particular patients, and they did well. They were able to complete their treatment options by just decreasing dose. Any similar type situations for you?
Yes, we've had patients who, so let's say we've had to do lower doses, not only because of shortages, but you're right. Some patients don't quite tolerate it as much. And this goes for really any of the intravesical treatments. But for BCG, it is nice that we can kind of administer that lower dosage there, and then they're able to tolerate. But I've also had patients who were not able to tolerate their intravesical treatment period, and who had to stop completely and kind of reevaluate their course of treatment altogether.
Were you ever doing the combination of interferon A with BCG? We
did for a while there. Not as of recent, but yes, we certainly did that for a while.
Yeah. I think it was a Dr. McDonald, if I remember right, something along that line, that had done a lot of research, and that protocol actually called for a lower dose of the BCG, like a 1/3 dose mixed with the interferon A. And we were utilizing it for patients who failed BCG by adding the interferon to it. And we had some successes. Like everything else, nothing's 100% effective.
Absolutely.
Fanny Persons said, what are the long-term risks for patient who is receiving the live bacteria for prolonged time?
Yeah, that's a great question. So one of the biggest things that I'll stress here, so when we're talking about who should not receive that treatment, so when we're talking about someone who maybe had traumatic catheterization or post-surgical, aka they might have a sore in their bladder, it kind of relates with this question, because intravesical treatments, not just BCG, but say mitomycin, who's an actual chemo drug, they really just stay on the bladder, right? Now they can cause irritative symptoms and whatnot, but the main concerns when you're talking about a overall, full-blown body sepsis, et cetera, would probably be from it crossing from the bladder into your, bloodstream and whatnot. And so just the intravesical treatment into the bladder to a patient who is a perfect, candidate for that. So no, it should not be, there should not be any long-term full body effects, I guess we'll put it that way.
Yeah. Yeah, that's a good point. It's the absorption of BCG that's the concern. So that's why, as you stress, make sure that they don't have gross hematuria. Now, some of us who do urinalysis do, the test strips and it comes back positive, and then you look under the scope, maybe you see a few blood cells. And we're comfortable, our group is comfortable giving BCG because you are going to have, some microscopic hematuria, but the gross hematuria, you hold it up and it's red. Those are the ones you want to avoid, because that's a patient who probably has an open area of the bladder that could absorb it. I think that you're always looking to decrease those side effects. Any great stories to tell about patient success stories?
Well, there's lots of patient success stories, I guess. Let's see here on the spot, Vic.
Okay, I'll kick it off. I'll tell you one of mine. So we had a patient, I was involved before BCG was FDA approved, and I worked with a 3-person urology group at the time. One of the doctors was very proactive in jumping on the bandwagon for everything. So he had gotten involved in BCG and wasn't part of the study, but was using it off label as part of somebody else's study. And so I got involved with him doing that. Now, one of the other partners had a patient with young guy, recurrent bladder tumors. And, this is really a tough thing for patients to have to come back, have their cystoscopy, and they're told, you got another tumor, we got to go back in there. Even though it hadn't progressed, it was still going through another surgery. And they think like, well, this cancer is never going to end. Again, a young guy. And this had happened. And I talked to the other urologist. And I said, your buddy's using this BCG stuff, and it's I've had some pretty impressive results. I said, would you like to try this guy on it? So we did. We put him on this. Well, this guy, he went through his course of BCG, never again had a recurrent tumor. And, for a while, I'd see him all the time. And he got to the point where he was on his once a year cystoscopy. And I think it was about his decade, a 10th year. And he comes up and he goes, he says, I'm so glad you talked to that doctor into trying that medicine, because he says, no more tumors. So, I mean, it's, for not all cases are going to be like that, But when it's that, dramatic, it's really a great story.
Yeah, no, that is a great story. Out of curiosity, then too, Vic, do you have, a lot of our bladder cancer patients, unfortunately, are smokers,
Yeah.
right? What would you say is the percentage of patients that, once they have that diagnosis, they're kind of going through these treatments, which, it's not easy. You do cystoscopies and, you have to have surgeries every once in a while. Sometimes you need little biopsies, bladder treatments. I mean, you name it, it's a long road, right?
Yeah.
I have a lot of patients that don't give up smoking, even though we talk about it. And, I would say actually more than 50% don't stop smoking. What would you say is your experience?
Yeah, that's a good point. And I think that in my experience, the patients who continue to smoke more than likely are going to have another recurrent tumor. Much better percentages if they stop smoking. And it's always, I never smoked myself, so I can't really comment the nicotine habit, but it's definitely a tough one to quit. And I think that convincing patients. So the first time they'll probably not listen to you.
Mm-hmm.
Second time, third time, I think some of the doctors have said, this could be your bladder being removed in the future.
Mm-hmm.
And I think sometimes, you have to give them a real dose of reality. But as you said, they'll still sometimes smoke. I think we all have had the case of patients who had tracheostomies and they're smoking through the trach. So, that's the reality of it, but it does happen. Hey, I got a question for you. So you give 6 weekly treatments. Do you know why it's 6 weekly treatments?
I don't. Great question.
So you would think there was some fantastic study that showed 6 was ideal. Now, I will tell you that have been studies that have conceded that 6 has been the perfect amount.
Mm-hmm.
The reality is it came in a 6-pack. The medication was shipped in 6s. So it had nothing to do with science. It was strictly just coincidentally came in a 6-pack. That's how they decided to give it. And it just kind of withstood the test of time. Now, there's been other protocols that have looked at using lesser doses. There was a study, and I can't remember who did it, but they looked at the bladder after each induction study for changes. And they said they started to notice this immune response after about the second or third dose. Mm-hmm. So we know that it probably takes at least 2 or 3 dosages. And I know with patients, normally I always tell patients that, you may feel perfectly fine the first 2 treatments and you'll think we're doing nothing. I said, then the third or fourth one comes along and now you may get a little bit of that burning frequency, the irritative symptoms. So I warn them. I said, and that's not a bad sign. That just means it's working. Mm-hmm. Same thing with their urines. You might suddenly now start seeing more white cells showing up in the urine when you look under the scope. Again, that's just that immune response has to take place for it to work.
Yeah, no, very true. And really, that's a great point, setting the expectations with the patients, right? Because sometimes we may view things like urgency, frequency, kind of that low-grade fever as, ooh, this is not good. But it is kind of doing its purpose, right? It's the body is reacting to that medication, which it's what we want. Now, you don't want it to be an overreaction where you're concerned for your patient with a high-grade fever, et cetera. But setting up the expectations of, what it will be like after they leave the office, it's very important. I mean, needless to say, obviously setting up the expectations of what the experience in the office is going to be is really, really important because it's invasive. It's a catheter. Someone's half naked. I mean, it's a very sensitive treatment, but setting up the expectations for after they leave you and they don't have you right there to ask questions right away. Yeah, it's so important.
And I think, like you said, having handouts that you can give the patient to take home. So at least they have something to refer back to. Oh, okay. Yeah, this is normal. So I don't need to be calling or this I better call about because this is something I need to worry about.
Yes, absolutely.
Another interesting point, you'd mentioned somebody who you leave a catheter in if they have trouble holding the urine and just draining it off in the office. We've done that in the past. The one thing I always like to make sure I know, especially my male patients, are elderly ones, are they having retention? So if a patient, for instance, is one of these guys who's getting by, but he's still walking around with 100, 200 cc's in his bladder, he's not the type of patient you want to send home and just tell him, go ahead and empty your bladder at home like we do with most of our patients. He'd probably be somebody that you'd want to catheterize or have them do intermittent cath. And we've done that before.
Yeah, that's a very good point too, Vic. So again, needless to say, knowing your patient, right, and knowing their history, as you mentioned, sometimes you might do a urinalysis, there might be a little bit of blood, you might be comfortable with it. You know, it's each individual patient is so unique and should be treated accordingly. But yeah, no, that's a really good point.
And you always got that patient out there who, if 1 aspirin is good, 2 aspirins is great, 5 aspirins is fantastic. You know, so they think the same thing. Well, if I hold it for 2 hours, what if I went for 3?
True.
Would it be better? And I think that, you know, you really have to kind of tell them, no, we don't want it longer than 2 hours.
Very true. Very true.
All right. We do have a comment coming in. Jennifer Shipstad, are you doing UAs with every weekly treatment? We don't. We do one week 1 and only repeat if suspect infection. What are your thoughts on that?
We do weekly urinalysis. We, you know, with prior to every treatment. Now, say through the middle of the treatment, we're kind of like, oh, this patient usually doesn't show this or that in their urine. We might send it for a culture and kind of wait on that before we proceed with even the next appointment. But we do weekly urinalysis. But again, knowingly that every patient is unique, right? And so everybody's urinalysis is not going to look the same when the provider does choose to move forward with that treatment.
Yeah. I think what Jennifer might be referring to is the confusion that you'll get because, as I said, as we're treating, white cells are going to start increasing. Yeah. So you'll see it. Now it's normal. We do a UA on every patient, and I'm not doing it for that. I'm looking for bacteria. I don't want to see, you know, when we do a urinalysis, we don't just go by the dip test either. We do a microscopic with it. And I don't want to see bacteria in the sample because then we'll hold the treatment.
Exactly.
And again, as you stressed early on, everybody's protocols are going to be a little different. Make sure you're following what your physicians and you have established as the safe protocol for your practice.
Absolutely.
Heather Hansen, do you ever have a patient who needs a Foley catheter for the 2 hours and find out they leak around the catheter because they just can't control the treatment? Heather, I've been waiting for this question. I got an answer, but I'm going to see what Lais says. Go ahead.
Yeah. So it's yes. So depending, I guess, on how severe that leak is, if someone really cannot tolerate, if there's so much leakage that is just not even, you know, it's super forceful and it's kind of defeats the purpose of having the catheter and all the things. This might be when you're evaluating, you know, reevaluating, is this the right thing even for this patient? Is it going to work? Is it going to be worth it? Kind of, again, going back to each individual patient having a unique experience. If it's not too crazy, right, of a leak, and maybe we find that we can hold I don't know, maybe the patient had a pot of coffee before they came. I don't, you know, just kind of making it up here. Or, you know, there's maybe they can have some Levsin or something in those lines if it's not that severe. But if it's really severe, it might not be the right treatment for that patient.
All right. So let me see here. I'm going to kick over to the full screen. So Heather, I'm going to show you my treatment option. Anticholinergics, number one, get them on something that can hopefully relax their bladder, but that doesn't always work. Somebody with a very spastic bladder with the closed system where you've got the BCG in a bag and you've got a tube coming down to the Foley. What I do is I put that on put this into the patient and I leave this on just like that on a IV bag and leave it hanging next to the patient. So what happens when they get a bladder spasm, the fluid goes back up into the bag. As soon as the bladder spasm relaxes, it goes back into their bladder and fills their bladder. So I found that that's been one way to really successfully go ahead and keep somebody who otherwise would be unable to have the treatment because of the severe bladder spasms and it's worked countless times. You have to have a closed system so that it can flow back and forth. But unless they really, really have bad contractions, it'll keep it in their bladder and get the treatment treatment performed. Susie Swain, we have patients do a urinalysis the day before the treatment. Yeah, can't argue that. That was reasonable. Again, I think you just want to make sure they don't have an infection mostly.
Yep.
And Nancy Brownlee, we have our patients rotate their position every 15 minutes, back side, abdomen, other side. Maybe you mentioned positions. This is done for 2 hours in the office. We can send them home if compliant with instructions. That's something I always tell patients to do. Don't just sit in a chair somewhere and stay, like a statue for 2 hours. You want to rotate.
And that is part of the insert. When you look at the BCG insert, it does talk about, kind of moving around and whatnot, being active. You're right. Don't just go take a nap for 2 hours, right? I actually joked one time talking about a patient going maybe on a trampoline and just, hanging out like that. Don't do that. Don't do that. But
jump rope, anything.
Just regular, moving around, making sure it's kind of doing its thing all over the bladder.
Yep. And patients, I think, can be trusted with it. They're pretty good about it. You tell them, if they kind of know what they're doing, they want to try to slush it around in there. Have you tried the Cunningham clamp? That the Cunningham clamp is an idea, but if they get a forceful enough contraction, it's going to spray out even through a Cunningham clamp. Yeah. So it kind of depends. Patients that have just like kind of, I think maybe a sphincteric issue where they leak, Cunningham clamp would be an option. And Heather Hansen says, thank you. So I think we may be getting to the end of our questions. I know we're getting close to the end of our show. Any other questions, folks? Go ahead and put them in now. It's really great discussion. I think we covered a lot in BCG. And I think for the folks that are getting into BCG and they're new to urology and just starting out, the things that you mentioned about precautions are really important. This is a medication that has a risk of causing contamination to you and to the patient and to the people in their house. It's a live organism, so you want to make sure that you treat it with the appropriate precautions, and having the bleach so that they can kill it off before it gets released into the wild, so to speak, by treating the toilet. And these things are important. With bleach, I always caution patients to be careful when they're using it, because bleach used straight is pretty caustic and it can cause skin burns. So always tell patients be careful when they're pouring, not to do a high pour, get down close enough to the toilet that they're not getting contaminated. But I can tell you that I've seen very few, if any, patient family members that have developed tuberculosis from BCG treatments.
Right. No, likewise. It's just, I think, obviously immunocompromised individuals are obviously at higher risk. So.
Hey, Andrea, welcome to the show. Only an hour late, but that's because we started an hour early.
Oh my gosh. Dang, I do remember that you said that now that dang it.
You missed a great show, but do you have any comments before we leave on BCG?
I do not have any comments today. Sorry, I missed it, everyone.
No, not a problem. It's unusual that we're so fixed to always being on at 9 o'clock, but I've had a couple of instances where, due to speakers schedules not being flexible enough to do it, that I've had to go ahead and change the time. And here comes John coming in too. You didn't catch the memo either. We started an hour early, John. We're at the end of the show.
Oh, that's okay.
but it went really well. Lace and I handled it just fine. But I did want to bring you guys in since I saw you coming on the screen. As I was saying, sometimes we start an hour early if there's issues going on with people. I also I've got a family wedding that I have to get to that's out of town for me because I live in Indiana now. So I said, well, okay, an hour early wouldn't be such a bad thing to try to get everything wrapped up. But really great discussion on BCG. I think, you covered, as I was saying, Lais, you covered everything that we need to, for people that are new, especially to the use of BCG. That's really important.
Oh, I'm sorry, I missed the live.
Yeah, that's okay. You've got to get up really early, but Susie Swain was up. That's all I can tell you. She made it on time. But yeah, so next week we'll be at our regular schedule again, 9 a.m. So no problem. And I think I forgot to mention at the last show that we were going to be starting an hour early, but I did have it in our things. And Katie says, "That's so funny, Andrea."
I was setting up the lamp behind me for the show.
Looks nice.
Thank you.
How was and you were recently in Europe, right?
I was. Yep. We went to Paris.
Wow.
And we also went to Iceland.
Oh,
it was awesome. A dream. It was exactly like I imagined it would be. It was an absolute dream.
Yeah. Very good. All right.
Hey,
well,
are you using your microphone, Andrea?
I thought I was.
Oh, okay.
Are you able to hear me?
It seems like it's
echoey,
I'm hearing a lot of reverb.
It may not be turned on.
Andrea,
properly.
can you tap the microphone capsule? Yeah, it sounds like it is. Okay, can you bring it closer to your mouth and speak into it?
Testing.
I don't think it's picking up on the microphone.
Yeah,
okay.
But we usually work that out in hair and makeup anyway. Well, I'm going to go ahead and bring into the close of the show, and you guys can hang on after the show if you want. We'll talk more. Let me just bring this in here. So next week we have Kelly Casperson joining us for our show, and here's our little talk.
Dr. Kelly Casperson is a urologist, wife, mom, sex educator, and top international podcaster whose mission is empowering women to live their best love lives. Dr. Casperson's work has focused on the intricate connections between estrogen levels and various aspects of women's health. Her studies have highlighted the multifaceted influence of estrogen on women's bodies and its importance in maintaining healthy menstrual cycles, bone density, and cardiovascular function. Join us this week to learn more on the estrogen effect, transforming health and happiness.
And hey, in 2 weeks, we're going to be live in Phoenix. So join us. UroNurse will be at the SUNA meeting and hope to meet everybody there. And with that, I'd like to say thanks for everybody showing up for the show. Had a great show, and we'll see you all next week on UroNurse.